We're about to begin the next session on patient safety. As people continue to come in and settle down, may I invite our chairpersons to come and take their place on the stage. We are very happy to have with us Dr. Punitha, who's the former Dean of the College of Nursing and is presently the Professor and Head of the Department of Surgical Nursing. In addition, she's looking after the departments of research and continuing nursing education. We're also happy to have Dr. Sukriya Naik, who's a Professor of General Surgery and the Head of Surgery Unit 4.
Good afternoon and welcome to this session. Dr. Punitha will introduce the speakers, but before that, may I ask you whether you have taken the safety precaution not to slip off in this post-lunch session.
We warmly welcome all the audience and also the speakers to this session on patient safety. And I'm sure that all of you have been hearing a lot and bombarded with various concepts related to hospital safety. We are particularly going to look at the various factors associated with patient safety. And we have very good speakers. There are 3 speakers who are here. I just want to just place in front of you, within 2 minutes, the scenario of patient safety. All of us know that patient safety is a global issue and it poses a public health concern. And according to WHO statistics, we find 1 in 10 patients develop adverse events, and they are posing in developed countries, we will find 1 in 10 patients are harmed while receiving hospital care. So, and how much more in the developing countries, like healthcare associated infection is 20 times. And they just made just 2 comparisons between healthcare and aviation and nuclear plants. I was really alarmed to see what is the other ratio. We have they have 1 in 10 lakh in aviation, and healthcare, the probability of getting harmed is 1 in 300. So I think this is a very major concern, which plays a lot of economic burden. And many of the causes and many of the factors that are associated with patient safety, and what are some of the causes, what are the prevention and control measures, what do you have it in the WHO level, global, national and local scenario, I'm sure our speakers will be able to bring in. And patient safety is becoming a new discipline because of its immense importance and threat. It is becoming a discipline by itself. And we have 3 speakers who are going to speak on 3 different topics. The first topic will be by Ms. Punitha Singh, who will be speaking to us on practices in wards towards patient safety. Ms. Punitha, she is a Director of Nursing of the Apollo Hospitals at Chennai. She is a very proactive nurse leader in nursing services, and I have met her in many of the places demonstrating this. She is our graduate, and she has done a PG in Nursing Administration and an MBA. And her leadership in JC accredited hospital is commendable. And she has received Award of Excellence by Deputy Premier Health Minister Queensland, Australia, for her outstanding nursing services. And she is in the expert committee, Tamil Nadu State Nursing Council. And she is a founder member of the Infusion Society of India. She has many papers and publications to her credit, and particularly want to say she has redesigned and restructured her work force and raised the standards of nursing in the Apollo hospitals. We are very happy that Punitha is in our midst, and she is going to speak to us on the first topic, that is practices in the wards towards patient safety. Punitha, Ms. Punitha Singh.
Felt gratitude for the organizing committee for giving an opportunity to talk about patient safety in the wards today. And I'm proud to be back in the midst of all of you. As ma'am said, I'm a CMC graduate. And I remember getting onto the stage for my graduation, and then I think it's after so many years, it's now. And best wishes from Apollo Hospitals to all of you and to the organizing committee. And my compliments to the hospital administration for making this happen. We all know, past 3 to 4 years, I think in the Week's magazine, CMC Hospital is number 3. That is number 3 in the national level and number 1 in the private sector. You did not take it for granted. You still felt that it is important to, reinforce and emphasize on patient safety to all the staff. So this really speaks that you are set out on a great journey. My topic, the topic which is given to me is patient safety on the wards. Wards are mainly managed by the charge nurses, and probably you might think it's the nurse's responsibility, but patient safety is every individual's responsibility in a healthcare setup. My agenda for the next few minutes is I'll be talking about the international patient safety goals, which actually covers the entire gamut of patient safety activities in the hospital. And how do I ensure patient safety? And little kind of extra mile that I'll be talking about the early rounds, attending call bill, structured handoff communication tool, having an IV team set up, and also compliance on the bundle checklist. What is patient safety? A simple definition on patient safety is that it is the prevention of errors and adverse effects to patient associated with healthcare. Few patient safety imperative that I wanted all of you to just have a look. Recent studies suggest, in fact, ma'am also talked about the percentage of safety related issues in various other areas. Medical errors occur in 2.9 to 3.7, almost 3 to 4% of hospital admissions. Out of that, 8.8 to 13.6 of errors lead to death. As many as 98,000 hospital deaths may occur each year as a result of medical errors. Now, this is a Western world's data. This is a developed country's data. They have the national repository where it is a national mandate for the hospitals to upload all their data in the repository for people to have a look at it and choose the best hospital where they want to go and get treated. But unfortunately, in our country, we still haven't grown that far, but I think the insurance companies are, the regulatory authorities of the insurance companies are now making it mandatory that all the infection, the data, related data and other safety aspects needs to be uploaded, and I'm sure that would become a way of life sooner or later. And also a recent study which says that 2% of hospital admissions have a preventable adverse drug event, resulting in increased length of stay to 4.6 and increased hospital cost of $4,700 per admission. Now, healthcare is becoming more corporate these days, business-oriented, profit-making, and having a control over the average length of stay is a primary importance for all the healthcare members. The hospital can make revenue only within the first 2 days or within the 48 days of admission by investigations or various referrals or any procedure to be done. But if the errors are going to contribute to the increased length of stay, it is going to be detrimental for the organization which is looking at profit. I want you to also have a look at this safety culture. It really requires a paradigm shift, a different outlook towards safety. Earlier, when there was an incident in a hospital or in an area, immediately the question is, who did it? And the focus on the bad event by doing a root cause analysis, literally doing a postmortem on something which has happened. And it was always a top-down approach where the administrator tells you just have to do this and you just do it. Sometimes you have an attitude, you don't even feel like doing it. And if you had done a mistake, the first and the foremost thing was penalty. How to punish this person, get her out of the system, she can't fit to work in this place. But it does need a shift, and this is how it should be looked at. Instead of looking at who did it, look at what has happened. And instead of doing the root cause is a reactive way of dealing with an incident, but look at FMEA, that is the failure mode effect and criticality analysis, proactively doing something to prevent certain errors. And it is a bottom-up approach, and instead of just penalizing a person, look at the process and fix the process. How do I get the data and the details of patients at risk? Now, we need to have a safety culture in our environment. We need to change our attitude. Now, here there's a lot of counseling, training, repeated training is needed to bring in the safety culture. It's years since people have taken actually safety for granted, but we can't do that anymore. The time is not there for us anymore to take it for granted, so we need to bring in a safety culture over here. Now, how do we get data? Incident report. Ms. Lalu was talking about the incident reports. There are many places probably people are really not reporting the events. Now, how do you bring in the culture? Underreporting can really be bad when we are really looking for a safety culture. Now, underreporting, again, when you have a thought process that somebody who has done that mistake should be punished, or if somebody is going to report about a patient fall, and if you're going to do an RCA and find out since the side rails were not up and she is responsible for it and you would punish it, that person may not even bring it. But instead, what we need to do is to fix the system and encourage the people to do event reporting. You can even bring in a system that, whoever kind of reports the most number of incidents during that month for that particular ward, they can be awarded, so that culture would slowly change. And also, normally the quality system or the safety cell would have the root cause analysis or the FMCA and quality monitors. Now, when I talk about quality monitors, I do not know whether in CMC we have quality monitors for each of the department. Now, because I'm from nursing, there are some very nursing-related or nursing-pertaining quality monitors which we look at, like patient fall, needle stick injury, medication administration errors, and pressure. So these are very, very nursing-related indicators which needs to be captured, monitored. Deviation should be escalated, and it should be put on the notice board for everyone to see, so people will have that culture settling in. Now, I told you about the International Patient Safety Goal, which would actually cover the entire gamut of patient safety in the wards. There are 6 important goals which we need to look at. One is identifying the patient, effective communication, improve the safety of medications, surgical safety, reduce the risk of infection, and also reduce the risk of patient fall. I'm actually rushing in because although I tried my slides to limit to 28, I think there's so much for me to talk, so I'll just try to kind of do justice to whatever I'm presenting. Now, starting with identification, I'm sure all of our patients are having the identification band upon admission, and we do not receive the patients without the ID band. But how many times are we really checking the identity of the patient? And the name alert, a unit which has about 40 beds, we may have 3 Subramaniams or 3 Shivakumars, but how are we knowing? We might end up giving a wrong medication to the patient. So we need to have something called a name alert sticker which needs to be put on the patient's file or the folder, so when the nurses go back to check the investigations or the medications, they know that there are 2 other patients with the same name. They go back and counter check again. And these are the times where you really need to check the patient's identity. Please do that correctly before administration of medications, administration of blood and blood products, taking blood and other specimens for clinical testing, any treatment or any procedure, or while shifting the patient or prior to the, prior shifting the patient for any investigations or procedures or for surgery. And also every time when you go to the patient, just before seeing the patient, make sure that you're talking to the right patient, the right thing. And the second one is the effective communication. Why communication is very important? This is the age of communication, but unfortunately communication is very, very less. People are so comfortable using the gadget, but they are not comfortable with face-to-face communication. It's very, very unfortunate. But in healthcare, we can't afford to do that. Communication should be timely, it should be accurate, it should be complete, unambiguous. Don't just guess, just tell what is exactly there which needs to be communicated. And you should understand what your, the other person is trying to tell, and also you should communicate in a manner that the other person is trying to understand that. Do we accept verbal orders? Now, this is a big question. Every hospital would say, verbal orders should be given. But there are a lot of concerns on this verbal order. People would give an order and that would be taken in the right sense. But if something goes wrong, the person who has given the order would just deny and say, no, I never gave this order. So please do not accept verbal order. Maybe your policy has to change. Maybe your protocol has to be changed over a period of time. But a strict no, no, no for verbal order. Except in case of emergency. Of course, there is a way of getting around this. But in case of emergency, you cannot say that doctor has to come and write the order, but you can always take the verbal order, but make sure you follow the read-back policy. When I say read-back policy, for example, a doctor gives an order for insulin, act rapid 6 units, stat subcutaneous, or 13 units. Now, there's always a difference between this 13 and 30. So when you repeat, just say 30 or 13 instead of just saying 13 or 30. So read-back policy should be followed when you take verbal orders, and ensure that the verbal order is signed off by the doctor within the stipulated period what your organization is setting up. Coming to the medication safety, everybody knows that we need to follow the 6 rights. I'm not going to go into detail with that. Store high alert medications away from the patient. Either keep it in the nurse's desk or procure it from the pharmacy only when it is needed, because high alert medications can be really harmful if it is not utilized in the right manner. Hospitals will have its own list of medications which are considered as high alert, like KCl more than 2 milliequivalent per liter and sodium chloride 3% magnesium sulfate high concentration. These are all some of the high alert medication. If you look at the JCI policies, the 5th edition says, high risk medications need to get into high alert. Now, high risk medications are again narcotics and insulin and other things which needs to get into the high alert, so that it is really stored away from the patient's bedside. How do we handle the narcotics? It should be stored in an immovable steel cupboard with double lock and key, and the key should be handled by 2 people, so that access is just not given to one person. When you have to open a narcotic cupboard, 2 people need to come in. Awareness of LASA, that is look alike and sound alike, and avoid using abbreviations like U for the international unit. It can be misinterpreted as 0, and I'm sure all of us would have experienced that. And antibiotic stewardship is very, very important. Why I'm saying that is that, misuse of antibiotics should be controlled, and I'm sure the organization can look at a way of having an antibiotic stewardship. And surgical safety, ensure correct site, correct procedure, correct patient surgery. I'm sure we do have surgical site marking here. Nurses should be empowered over here. Nurses should not send the patient to the theater if the surgical site marking is not done. Nurses should not send the patient to the theater if consent is not taken. Nurses should be empowered to say no if the pre-anesthesia clearance is not done. I'm sure things are probably running perfectly, but I'm also talking for the people who are here from the other hospitals. Please empower the nurses. They can really ensure patient safety in many areas. Pre-operative checklist, I'm sure most of the hospitals are following. It is very important. Checklist culture should come in for patient safety. Timeout, again, although we have set rules as to how timeout should be done, many a times after the induction, it is the nurse who reads out the patient name and the surgeons and the equipments which are to be used. Basically, timeout should be done by the anesthetist before the induction happens. Reduce the healthcare associated infection. I think there was a topic on infection, so I'm not going to talk much about it. It is basically hand hygiene. How important it is for all of us to follow hand hygiene. Here again, nurses are to be given the autonomy to correct unsupportive healthcare professionals. We have done audits in Apollo hospitals, and we have found hardly 50 to 60% compliance, although we have separate infection control team which comes and does the audit, and every bedside has the hand rub. But somehow getting into that culture is very difficult. People are finding it difficult, but that's the basic and the foremost thing for prevention of infection. We can't do injustice to our patients who have believed us, trusted us, and come to us. We should not create any harm to them. And monthly audits by the infection control nurse. Develop infection control champions. You can identify a senior most nurse and give her an extended role to be an infection control champion for that particular ward to drive the infection control activities. And also empowering the patient. Now, this is really working out. If you can educate your patient saying that do not allow anybody to touch you if they don't use the hand rub, that's the best way of actually prevention of infection. That happens only when we don't want to change the way we think. Reduce the risk of patient harm resulting from falls. Now, fall risk screening and assessment, which I'm sure is becoming part of everybody's culture. Identifying vulnerable patients, that's patients above 65 and kids less than 16 years old, and the fresh post-operative, patients with a lot of comorbidities, patients with some medications, who can be considered as vulnerable patients. Placement of side rails, which is a mandatory requirement for the accreditation hospitals. Patient and family education, which is very important in prevention of falls. Avoid wet floor, grab bars wherever it is required when the patients are moving. Now, going an extra mile in patient safety, one is the frequent rounds. When we have the culture of making the rounds frequently, many errors can be avoided, many harms can be prevented. Attending call bell, now they say it is a nurse's call bell. I think that terminology should be changed. It should be a call bell which can be attended by everybody, and structured hand of communication tool, developing an IV team and bundle checklist. Now, frequent rounds, when you go, there are 4 P's to look at. One is positioning, if the patient is properly positioned. Meeting the personal needs of the patient, you can proactively ask, do you want to go to the toilet? Do you want any assistance for their eliminational needs? Managing the pain, and also placement of certain things which is just next to the patient so that they will not reach out very far or might end up in having a fall. This frequent round, studies have been done and they have found out that it reduces falls by 50%, reduces skin breakdown by 14%, reduces call bells by 57%, increases the patient satisfaction. When the call bell is reduced, nurses have more time to take care of the patients. Now, when the call bells happens, please keep your head up, look for the light. There are certain things which a non-nursing professional can assist with. Please do not say that it is the nurse's responsibility. Sometimes a patient might call just to assist in certain things. We have also done a study. More than 50% of the calls are non-nursing calls, but being attended by the nurses. So I'm sure everybody on the floor can do this. And some of the things only nurses can do is physically assist a patient and turn off any alarm in the monitor, offer pain relief, dealing with IVs, and explaining any clinical matters to the patient. Now, a structured hand of communication tools. At the moment, I'm sure certain hospitals, we still follow registers. Some hospitals follow the patient case file. But it is very imperative for us to have a structured handoff tool, which will have the patient details, background, and the scheduled time of medications, any diet changes, any special concerns, schedule investigations. What are the nursing care which is due, the patient and the family educations, investigations, when it should be done, and what is the report, any abnormal report to be escalated. I'm sure you all know what I have written at the side. It is S-bar E. Earlier it was S-bar, that is a situation, background, assessment, and recommendation. Communication and reporting should happen based on this. But later on they felt that yes, I is very important, that is identification, and then having the situation, background, assessment, and recommendations. But they also added E. E is the education. So education is very, very important. Having an IV team established, I'm not going to go into the detail. It has improved patient satisfaction to a great deal and has reduced IV complications, mainly the peripheral IV complications, where we are giving a lot of focus for central line related IV complications, but peripheral complications lead to a lot of phlebitis and extravasation, which can be very, very painful and detrimental to the patient. So this has actually reduced. You can actually have a look at it. And I just want to show you, the bundle care. I don't know whether we have those bundles in our critical care areas. So not just the insertion bundles, we need to have the maintenance bundles, which is very important. For the VAP, it is the head and elevation between 30 to 45 degrees, sedation, vacation, stress ulcer prophylaxis, and DVT prophylaxis, also hand hygiene. And when you look at, I'm sorry, Okay. The central line related bundles, again, whether assessment to be done, whether it is really needed, which has to be kept there, and dressing is done on time, and whether closed system is followed. And the next one. And also the COTI bundles. I don't think I need to go in detail with that. It is again similar, something similar to, yeah. Right, so I think I'm on time, and the first class patient safety will require everyone's best effort. It is just not the doctors or the nurses or just the paramedical. Everybody who works in the hospital, everybody who works for the patient first-class patient safety will require everyone's best efforts, and that's the message I want to just leave with all of you today. So I think I'm on time, and I hope I did justice. I think comments and questions will be done later, isn't it?
Yes, thank you.
Can I take 1 minute to play a video if you can? If you please
Yeah, we'll
allow me?
permit that.
Can I? Where's the video? Can you help me with that? Oh, yeah, okay. It is the video on the hand of communication. This is... Yes.
I am answering for this patient, Mr. Madhavraj. Shall we start the handover? Yeah. Identification. Patient name is Mr. Madhavraj, 68 years, admitted under Dr. Magesh Gopashetty. Coming to the situation, he is admitted for liver transplant package. And coming to the background, he is admitted for abdominal distension, melena, ascites for past 1 month, and he is non-case of diabetes for past 2 years. Now he is diagnosed as cardiac HPLC. Coming to assessment, last 24 hours intake is 1690 and output is 1250 ml. Now he is not having any pain score is 0/10, white sense is stable, temperature is 97.8, pulse is 92 per minute, respiration is 22 per minute, and BP is 110, 70 mmHg. And all the investigations are done, only the dorsal abdomen is waiting for the results, all other are finished. And coming to the recommendations, patient is getting tablets like Cevit, Shelcal, Volvic, Trizadel, and he is getting antibiotics of injection Magnus 3 gram. Patient oral intake is very less, so I have given indications regarding increasing oral intake. Now patient is waiting for a cadaver. Whenever he gets cadaver, possibly for transplant.
Okay, now this is a small video. The hand of communication, using a hand of communication tool, that's a KARDEX. She just finished that, the reporting of that patient within a minute, hardly a minute's time. Now that really helps, which gives all the details, and this actually in a liver unit where a patient, she's giving a report on a patient who's waiting for a liver transplant, and in a very structured manner. Maybe the audio was not quite clear, I'm sorry about it, but please start following all these things, and I'm sure we will be giving a very safe environment for our patients who are trusting us and coming to us. Thank you so much. Thank you for the opportunity given.